Welcome to this morning. Glad you're here. Glad you're here virtually. We wish you were here with us in Cleveland, but we're thrilled to sponsor Association Forum's Healthcare Collaborative. We were actually set to host a meeting of yours in March, and COVID hit like it's hit the rest of the world, but we're thrilled to have you with us here virtually. Again, I'm David Gilbert. I'm CEO of Destination Cleveland. I just want to give you a little bit of a welcome. For those of you who haven't been to Cleveland, usually when people are here, we love to show them a lot of the attributes. It's a tremendous city with great assets in sports and parks and the lake and a lot of great stuff. I think as someone who grew up here and is very passionate about this community, raised my family here, I like to think more about what makes us special, what's the soul of this community. Really think of us, we're a very passionate, deep-rooted community, very resilient, diverse, and a city that's been through a lot of ups and downs over the past couple of decades and come out as a very proud and strong place. And I think it's part of what makes us very unique and special and growing. One of the other most important attributes in our community is our incredibly strong and outsized healthcare community. It's become not only a huge strength for the people who live here, but an enormous part of our economy. We are so fortunate to have three major health systems in University Hospitals of Cleveland, Cleveland Clinic, and Metro Health System, have patients truly who come from all over the world for some of the best care that is seen around this country and around this world right here in Cleveland. I will tell you, our organization, a big part of what we do is to attract people, change the perceptions of Cleveland, and in most of our types of organizations, bringing people to town is about filling hotel rooms and having people spend. For us, certainly that's important, but we'd like to think more about what we call harnessing the power of the visitor. Who is it that's most important to us to bring to see our community, to change their minds, to see this as a place to do business, as a place to live, as a place to get healthcare, as a place to invest, as a place to retire, and so on. And healthcare is absolutely at the top of that list. And so just having you even virtually connected to us, we place an outsized importance on the role of having healthcare professionals here in our community. One last thing I would mention before I make our important introduction to our speaker, a little bit about what we have done during COVID as it relates to health and safety. And early on, clearly a recognition that health and safety of visitors rose to the top of the number one consideration of whether people would visit. And certainly when all visitation stopped nearly, that was critically important even in locals' decisions everywhere around this country of whether or not they would interact with their community. What we decided to do very quickly was create a program to get people to feel as safe and comfortable as they could if they were in restaurants, in hotels, in venues, and other retail type establishments. We created a program called Clean Committed. We developed a basic set of guidelines. I say we, it was actually done in coordination with all three of our major health systems, along with our county and city boards of health. And we had businesses, right now over 700 businesses, who signed up to be part of the program. When they signed up, they received materials to put in their establishments, on their windows. They were immediately put on a website, an app, along with receiving safety kits. We got funding for and assembled over 300,000 free safety kits for individuals, which included hand sanitizer, face mask, great information on staying safe. We've distributed over 200,000 of those through the establishments, through neighborhoods of need in our community. And we've had tens of thousands of people who've used that list to help decide where they are going to go in terms of interacting with their community to feel safer. So something we're very proud of ongoing. It's been written up as really a top program in the country for a community coordinated response to COVID. So that ends my portion, and now I get to my most important duty, and that is to introduce our speaker, Dr. Patrick Runnels from University Hospitals of Cleveland. We're thrilled he's joined us to impart his wisdom in the next part of our agenda. I'm going to read his bio here. Dr. Runnels, Patrick Runnels, currently serves as Chief Medical Officer, Population Health, Behavioral Health, Director of Adult Clinical Psychiatry, Public and Community Psychiatry Fellowship, and Population Health Education and Medical Director of Emergency Psychiatry at Cleveland's University Hospitals. Dr. Runnels attended medical school at University of Missouri Columbia, completing his psychiatry residency at Mount Sinai Hospital in New York and the Public Psychiatry Fellowship at Columbia University. Academically, he is an associate professor at Cleveland's Case Western Reserve University School of Medicine. He has served as the co-chair of the National Council Medical Director Institute and chair of the American Psychiatric Association's Council on Government Relations. Most recently, he completed his MBA through the Executive MBA program at Weatherhead School of Management and Cleveland's Case Western Reserve University. We're proud that he's a Clevelander, proud that he is part of our community, and great in terms of his busy calendar that he's agreed to join us today. So Dr. Runnels, I'll turn it over to you, and thanks again for being here.
Thank you so much, David. Really appreciate the introduction and very much looking forward to our the chance to talk today. I need just a second here because I'm going to be sharing my screen and pulling up a PowerPoint. While I'm doing that, I want to just say a couple of quick disclaimers about the presentation. The first is this is a presentation that ostensibly talks about COVID. And our experience with it. And something I want to emphasize is this is a presentation with not small amount of positivity in it. And I want to just be really, really clear that, you know, it's obvious that COVID has been just an awful experience for so many people in so many ways. And just want to make it clear at the outset here that as I start talking about some of the work we're doing here and what we've done, I don't want the message to be that we don't take seriously how much difficulty and pain that this has caused, not only in the toll of human life, but also in the disruption to our economy and our health and our well-being. The second is there is a chat function, and oh, there it is. So I do have the chat function pulled up. I am going to make some as people put chats in, I may very well answer those if they're directly related to the topic we're talking about. And I also may go ahead and choose to wait until later. So just because I'm not answering your question in the moment doesn't mean that I don't value it. It's just something I think may make more sense at the end. So with that, the last thing I'll say, obviously, is as David pointed out, I was born and raised in Missouri, moved to New York City, lived there for 5 years. I've been in Cleveland. It's been my home for the last 12 years. I am, as he suggested, a very proud Clevelander, and think it's one of the hidden gems for a whole variety of reasons. And that's after having lived and had a great experience living in New York City. I really do think it's got a ton to offer and proud to represent in that regard. So with that, so this presentation is going to be kind of a mix of some ideas that we discuss. Also, there's going to be a narrative piece to this. And so as people are experiencing these different pieces of this, by all means, jump in with your questions, your responses. And my hope is that above all, it generates some discussion at the end. So we're going to talk a little bit about kind of the experience that we had at university hospitals in terms of dealing with COVID. My background is as a psychiatrist, and so we'll be spending some time kind of going over the example of what our department went through, which in some ways actually really led to a revolution for us in terms of leveraging and using digital technology for healthcare. So we'll be exploring kind of the experience we had with COVID, talking about how that caused us to have to change how we approached care we delivered, and then actually think about that as it relates to the future of healthcare and our population from both the patient perspective, but also from the provider perspective. So a couple of things that I will call preamble. The first is what healthcare is and what it's about. And so my job title is population health. And what population health has come to mean over the last several years is a change in perspective for how we as health systems approach care, from thinking about things in terms of volume, making sure that we're getting people in for treatments that we provide, to really thinking more about the overall quality of the patient population we serve, over the amount of cost, the amount of money we spend on getting that quality. And quality itself is both a function of outcomes, is people's health getting measurably better, and of the patient experience. Is it a reasonable experience to go through to get that result? And these are questions that healthcare systems haven't been incentivized to ask in the past. But over the last several years, we've had a lot of innovation in what we call alternative payment models, to start holding healthcare organizations accountable for those things, which means that we're all starting to look at how we provide healthcare in a different lens. For example, if I'm an orthopedic surgeon and what I do is operate on knees, previously my main concern was very focused on someone in front of me, do they need a knee surgery or not when I see them, and then getting the knee surgery done. And those are really good things. I don't want to take away from that. And our healthcare system, for the most part, does those things really, really well. The way we talk about it is, when you are sick, we help you heal in a hospital from acute sickness pretty darn well. We do pretty well around the world in terms of those results. What we haven't been responsible for, and what we haven't really thought about in any kind of systematized way, is what it means to ensure that the overall quality of outcomes for a given patient or a patient population are actually continuing over the course of the long term to show an increasing trend in health quality for a reasonable cost, and ideally for the most efficient cost you can give. So if I'm an orthopedic surgeon, I previously brought everybody I thought into knee surgery when their knee got bad. A way of reframing how we might approach that, though, is, what would it take for us to prevent people from needing that knee surgery in the first place, so that we're only doing knee surgeries when they're necessary, as opposed to waiting for people to kind of have their bodies break down and then wait for them to come in and then apply the treatment at that point. We call that shift in paradigm being, we need to shift from seeing people and helping them heal in hospitals, to shifting to keeping them healthy at home. And how do we best do that? So that frame is something that's hanging over the conversation we're going to have today. The second thing I want to kind of point out is that, for the most part, that frame has created one that is reactive and transactional. We wait until someone has something that breaks, whether that's developing diabetes or having a heart attack. They show up to us, and we see through that frame that our job is to react to that by providing a unit of service. That's essentially how we've been. It's somewhat, at this point, provider centric. You come into me because I do knee surgeries. That's very transactional. I give you a knee surgery. We think that we need to shift to a frame in which we're more proactive and more relational. And what that means is, instead of waiting for that thing to break, what is the consumer experience like that would get you to engage in care more effectively? And I think it's really important to point out here that everyone has had the experience of trying to engage in a healthcare system to prevent something from bad from happening, wherever you are in the country, and experienced having it be somewhat difficult to engage, to get an appointment scheduled. Who here has had trouble getting a medication filled or getting a refill called in so that you could get stay on a treatment that you need? Those things aren't necessarily all that well designed to be relational to the consumer's experience. And that, to a degree, is the story of what COVID forced us into with regard to working with patients. So with that preamble, very quickly, virtual care. So prior to the COVID crisis and prior to 2020, virtual care was something that we had a lot of trouble getting up and running. We were these people in the bottom right corner here, right? We were the person in the office that was embittered, feeling very strongly that we needed to do some telehealth because we thought it would be a really good mechanism to expand access, get patients more adherent, and also make things more convenient and potentially save a little money in the long run. And the hospital systems, in their suit and tie, were very against. We had a lot of trouble letting us move forward. And I say hospital systems, but it's very clear, whether it was a hospital system or it was an insurance company, whether that is Medicare or a private company like United, there were a lot of barriers that were erected, and there are a lot of reasons for those barriers to be there. Those barriers included things like concern that virtual care would displace jobs in rural areas now that people can go to urban centers for highly specialized care by video. Concerns that providers like myself who prescribe controlled prescriptions would use virtual care as a way to proliferate bad practice and expand potentially harmful medications to a larger audience, and or even if I'm not harming people, kind of expanding practice in a way that would expand fraud. And at the same time, insurers didn't have a really good sense of what the value they're getting from virtual care. They hadn't done any large scale trials. There hadn't been any large scale experience. And insurers are conservative about how they want to pay for things and are reluctant to expand things at a fast rate. My own personal experience is that in our department of psychiatry prior to 2020, we had a couple of areas where we were doing virtual care with some robustness. In particular, we were leveraging video care in our emergency rooms, and had a team that was at a central office that would beam into all of the emergency rooms. There's 18 of them in our system, that would beam into those and see people by video. But the number of visits we had done for people who weren't in the ER was, I would say, well under 1% of our book of business. It was essentially something we were piloting. It was hard work to get a half day of one person approved to do virtual care. And that had a lot to do with the fact that insurance companies were just really not paying for it except for in very specific circumstances. So the experience we had was very minimal. Now, our system for some time had seen the future potential of virtual care. I'm at university hospitals. Cleveland Clinic we talked with them. They had also seen the potential for virtual visits as being a treatment of the future. Despite all the planning, though, we were very lightly tiptoeing into this range. Now, psychiatry is a really easy place to do virtual care because there's really not a whole lot else that goes on in my interviews, but other than talking and relating. So I don't need a whole lot of other equipment other than good video equipment. That gets more complicated, but let's be very clear. We had, and we're talking about innovations in doing virtual visits for post-surgical follow-up. There was even, there's all kinds of innovations out there where I can even do certain minor procedural things virtually, whether that's getting you a blood pressure cuff so you can do your blood pressure at home, or figuring out how to take your blood sugar from home, or even, frankly, having the ability to look at rashes and do other kinds of things and get information from computers and things that we send to you. So there was a lot that was developing. Very little of it was actually being implemented. Then COVID hits. And I, by the way, had to spend a long time finding a picture of a tsunami that didn't show terrible things happening to lots of people. But this is actually a fairly good representation, in my mind, of what the experience of COVID was like. And what I want to point out here is we, the healthcare industry, were used to doing things the way we're used to doing things. The tsunami, and that's a word that's been used, and I think you all have heard a lot, came at us in a way that we were wholly unprepared for and just had to roll with. And the story I'm going to tell over the next few minutes is really how we rolled with it. So COVID hits. I remember very distinctly, I don't know how many of you guys remember this, I believe it was March 13th or 14th was the Friday, in which in Ohio, we had no orders from the state. And then on that Friday, so I went home that Friday thinking I was coming into work again on Monday. And then over the weekend, cases spiked. The governor gave an order, we were staying home, and basically essentially closed down all non-essential businesses. That happened over a weekend. So on the 13th, I went home in the middle of March thinking business as usual, and came back to work virtually on Monday, recognizing that everything was completely different. And over the weekend, there was a little bit of a call in a sense that this is what was going on. But the reality was it hit in about a day. Within a day, we went from doing things the way we'd always done them to having to completely reinvent what we were doing. What that meant in the Department of Psychiatry, and I'll start there, is we had to very rapidly figure out how we were going to get treatment to people who needed it in the most efficient way possible, complete without having them come into the office. And we all knew very quickly that what needed to happen is we needed to get virtual services up and running very quickly. Here's the thing. We had vendors that we were contracted with to provide telehealth services that was integrated into our EMR. But those vendors, and this is not a story just for UH, the Cleveland Clinic had a very similar experience. Those vendors were not prepared for the level for an exponential increase in the volume of visitors. Their bandwidth just wasn't there. We weren't able to get those up and running. We spent about a day trying to work and see if we could get that model up and running pretty quickly. And within about a day and a half, and this goes from about a Monday to a Wednesday, we had several changes happen nationally. The first, and a major barrier to virtual health, was that there are a lot of rules and regulations that the federal government has created that basically prevented us from being able to that put a lot of constraints on how we rolled out virtual care related to HIPAA and making sure that we were, keeping people's confidentiality in sake, relating to where we could be, relating to how HIPAA compliant the software and technology had to be. That put us in a place where if those rules were still in place, we would have had a very tough time doing this. Took about 2 days. The federal government by Wednesday essentially suspended all of the regulations and rules, as did the state of Ohio. All those things took about a day and a half. As soon as that happened, we were allowed then to literally pick any software we could, Zoom, DoxyMe, other vendors out there, and roll it out, because we didn't have to worry about whether or not we were in a position where we were violating any kind of rules. Furthermore, it took about 2 days for every payer out there, including Medicare and Medicaid, to also go from we're not so sure we're paying for all this to we're going to relax rules on virtual visits and restrictions from a payment perspective. That all happened in about 2 or 3 days. It's hard to give you guys a sense of how many rules how things worked that were essentially immediately suspended, and how business completely changed for those rules to be suspended that quickly, and for us to start submitting and get paid for services that previously wouldn't have been accepted. The amount of effort and work that went into that 2 days is hard to really capture, but it was amazing and it was intense. As soon as those rules hit, we had to pick a vendor. Now, in the Department of Psychiatry, picked Zoom. Our hospital did not have an identified vendor yet that it wanted to do. And again, other hospital systems in our area went through this as well. So the first order of business, what they said, it took a little bit of time, but what it said was, pick whatever you can do to get patients the right care right now. So if you can get them on a FaceTime on your iPhone, awesome. If you can get them to sign up for Zoom, awesome. All you can do is telephone, get them on, get the care that they need done. And so what happened in a lot of institutions, ours included, is that service lines, departments, all went with different models and different technologies to essentially meet the most immediate needs of getting care to the people who needed it. What that meant for our department was we had to very quickly identify the tool we were going to use, and then figure out how to get our staff trained and how to get patients facile and trained on what they were doing. And again, we had to do that very, very quickly. We picked Zoom in our department. Other parts of our hospital system picked DoxyMe. Other parts of our hospital system picked, we're relying heavily on things like WebEx. So we picked these, we went through it all, and then we had to, in about 3 or 4 days, something that would normally have taken me 6 months, we had to create job aids so people knew how to sign on. We had to create a workflow for our schedulers to call all of our patients who were needing visits, get them basically acclimated to what it means to sign on and get Zoom and get in through that. Get those people into a schedule, get the actual appointment set up, make sure that we then had a process whereby we could test whether or not people could do that, identify those people who had connectivity and internet issues, and make sure that they had the option to do things by telephone, and get that all in so that when the provider opened their schedule, it was clear to them what they were doing with each patient that day. And we're just psychiatry. We didn't worry a whole lot about pre-workup. We didn't have to worry about gathering any data like blood pressure or heart rate or anything like that. Didn't have to worry about any of that. All we had to do was connect 2 people by video. It's hard to explain how intense that work was, but we did that all in about 5 days, so that 1 week afterwards, we were up and running and had most of our patients dealing with virtual visits. So the first thing to note is that for the first few months, This is how we felt as providers. I don't know if any of you have seen the movie Anchorman. This is a famous scene from that movie. That's Will Ferrell, if it's not totally clear. But these are most of our providers and most of our patients were not really facile. People had used FaceTime for their family with their iPhones. They had used, maybe gotten on one web conferencing call, but most people weren't used to using this on a regular basis. For those of you, in other jobs, you learned that bandwidth connectivity was a big deal at your home that you didn't really previously realize. Lots and lots of us had kids, so our kids were jumping on virtual. We were jumping on virtual. There were two people working at home now that were both trying to use video visits, so the technology was coming in and out. People were discovering that their internet wasn't great. On top of that, patients had the same problems, and no one that we were calling, every single patient we called, there was almost no one that didn't have a lot of trouble getting in the first time. So if we typically had a half-hour visit and we were using 30 minutes of that, that we had to do all the work we were doing, we were very typically spending 20 minutes with people. And I have to tell you, this is how it felt. This is the experience that most people had. Looking at our primary care offices, they were having even bigger troubles because it wasn't, all we had to do in psychiatry was figure out how to connect. Our primary care partners in our system had to not just figure out how to connect, but also had to figure out how to gather really key and important data. And again, we're having all the same problems we were having and often had to do their visits by telephone. So that first few months was really, really intense. One of the unexpected things that we kind of realized was show rates went way up. So we previously had a show rate of say 10 to 15, or a no show rate of 10 to 15%. That went away. We had a 98% show rate for the first few months we were doing this. What that means is in our given day, we went from being used to working in a workflow we were used to, and seeing people, let's say, scheduling ourselves 7.5 out of 8 hours and then having a half hour to do paperwork, while also noting we'd have a 10 or 15% no-show rate with which to get other things done, to having to do all of that with a show rate of 98%, and also while using and integrating a new technology, often that technology, while trying to do the EMR from home for the first time in large part, integrating all of those things was killing people. So in one sense, we felt great that we had accomplished getting patients care. And in another sense, our providers were basically saying, we're working from 7 in the morning to 8 at night in a job that used to take us, 8 to 5. And so the pain was palpable. People were both enthusiastic and mission driven and also banging their heads against walls. Awesome. So fast forward another few months. We start to get the hang of the technology. The patients start to get the hang of the technology. This is how everyone's doing business. Patients have started to get into this a little bit more, understand it better. And so we're working this into our lives. And now we're working in this concept of what it means to work from home and telecommute. And to a degree, I put this in here because this is not the patient, this is the provider. Which is to say, this was not an unusual thing where the providers are now trying to figure out, okay, I got my kids here, I'm doing my childcare, I've also got to see my patient. And this scenario, as humorous as this might look, was actually not uncommon, that you had a parent who is now managing kids at home in a way they weren't used to, trying to get used to this. So the technology piece had gotten accepted, but then we had to kind of integrate this into our lives. And let's be very clear, there were still glitches, there were still connectivity issues. They were better, but they were still there. So it was still a harried time, even if it was a little less stressful. We were still hearing from our providers that they were still putting in 2, 3, 4 extra hours a day on a regular basis, and they were getting pretty crispy. This is where we are currently. And the way I'd say this is most of us have at this point set up our homes in healthcare when we can to do this virtual care with a lot more. We've all now bought fancy microphones. We've all bought fancy lighting. We've got good lighting. We've arranged our rooms just so. We've figured out that 2 screens is better than 1, so that we have one with our electronic medical record and one with our patient facing equipment. And at the same time, we're feeling this being owned almost by the technology. So the provider experience here is one in which we are trying to sort through this idea that I wake up and go into my office in my next room and sit down in front of technology all day long. And it's kind of the dominant way I'm working. One of the interesting things about telehealth and using video conferencing, whether it's for patient care or for meetings, is that you get more efficient. There's just a little less chit chat. There's just a little less informal back and forth. The commute to meetings is instantaneous. So everyone's days actually got a lot more technical and a lot more full in the same amount of time, which allowed us all to actually be a little bit more efficient, but robbed us of some of the humanity of that. And so this feeling that we have right now is one in which the technology is kind of driving us. We've got it, we're working it, it's making sense. Our days have come back to being pretty consistent with what we want in terms of the total day, but they're more exhausting than they used to be, even as at the same time, it's nice to be home and have our family around us a little bit more. Those two things are happening at the same time. Going back to a couple slides. So that's kind of the story of how we got there. Across other specialties, whether that's psychiatry, primary care, or other surgical specialties, there's been a very wide variance in exactly how much virtual care we're doing and exactly how we approach it. Right now, most of our medical specialties are doing a lot of their work, if not most of their work, still live and in person. Primary care has about 25 to 30% of the visits they're still doing either by telephone or by video. In psychiatry, though, we are currently at 98%. 98% of the work we do, tens of thousands of visits a year, is being handled virtually. My entire job right now is I'm able to do entirely from home. That's been an interesting shift, but we did that. We went from less than 1% to 97% in about 2.5 weeks. It took us that long. Changes that had previously taken a decade to start to come to fruition happened overnight. And that's that's what happens when you have a shock to the system that is a tsunami, is innovation gets massively accelerated. I'm going to talk a little bit about what the opportunities and experiences are. I want to shift briefly to talk about the patient side of this. So when we think about what the advantage to virtual health is, what was unclear to people before became really clear. But I want to be clear, virtual health was something that we were kind of looking at as a curiosity. And something I'd really want to emphasize is that in healthcare, we tend to design things based not on what will give patients the best access, but based instead on what makes the most sense to us at the time as providers. And what virtual care really did is it shined a big lens on the need to shift to this new thing that we at UH term patient-centered service design, but which has been percolating in the healthcare system for a while, which is the patient needs to be put in front. That needs to be the first thing. What does the patient need to get the best possible outcome? Then what are all the ways that we can most effectively meet that patient need? And then how can providers contribute to basically implementing those plans? If we do that, and we design things that way, we would design our healthcare system very, very differently from how we had traditionally designed it. And things like virtual care would have accelerated in a lot quicker. But we don't. We're looking at a whole range of other things. We make the contention, and I'm happy to talk about this more, that our system needs to change pretty radically. And I believe actually that this experience, at least with virtual care, has heavily influenced our push to go in that direction. So when you think about the experience that patients have, virtual care offers a lot of opportunities. And I've listed the big ones there. First, it is more convenient. And a piece of that I want to be very clear about is virtual care allows you, instead of taking a whole half day in which I have to take my half day off work to go in to an office somewhere, not necessarily near where I live or where I work, and sit in the waiting room for a very long time, that's really inconvenient. I lose a lot, I have a lot less, I'm losing a lot more of my time to make this happen. Most of the time, I'm taking at least a half day off to go get a routine visit done. So the ability to disrupt my life a lot less and give that time back to consumers is a really, really big deal. It's convenient. It's really easy to just be able to say, I need care. Even if I have the time, I don't have to drive off. I can just hop on my phone to get in and make sure that I'm getting this service. And so the opportunity to actually much more quickly connect with people is good. It allows better access. in psychiatry, most of our psychiatrists physically were located in the city center, in our Cleveland Medical Center. That's our academic center of our operations. That's where most of our psychiatrists are hanging out and about that area. But we have a geographic spread that goes way out into rural areas on the east side and way out west side to rural areas and south down to areas that are quite far away from major urban populations. That meant that psychiatry access was pretty poor. Virtual health completely changes that. That means everyone now quite quickly has access to what we're offering. And as I suggested, the other piece of this is all of these things mean that I'm more likely to get in and adhere to a treatment because it's more convenient and because it's less disruptive and because the access is clearer and more and easier. I'm going to get in, and that's awesome. These are things that patients really, really want. We did a survey just with the Department of Psychiatry and the patients we were seeing, and they actually reported, 77% of them reported that they were actually happier with virtual care than with seeing people live. This was better for them. Now, some of that related to their weighing in the risk of getting COVID when they're coming in. But to be very clear, despite all of the frustration and concern with technology, most people were very pleased with getting care this way. And that was numbers we saw across all of our specialties, and that's reflected in what we've heard nationally. That said, there are challenges. The first and most obvious is using these tools took people a lot of time. And when you're seeing people who haven't been inculcated with kind of the culture of using virtual tools, this was painful. Most of our patients figure this out pretty quickly. The very big and obvious one that's really struggled, that won't be a huge surprise, is our geriatric population. They are much more likely to want to lean on phone visits than they are to want to lean on some of the things like Zoom. It's just easier. It's what they know. The ability to adapt to those other types of technologies feels overwhelming to them. And that ties in to the second piece, internet infrastructure. This is something you may have heard about, which is virtual health's awesome. It's a really big deal. It's also, let's be frank, a privilege to be able to access, because many, many people with less resources and in kind of more difficult kind of areas where the infrastructure isn't built up don't have access to internet at home. And as a result, it's awesome that we're offering Zoom. It's just not something they have access to. So for those folks, we've been leaning on telephone, but that infrastructure piece has really come into sharp relief. Whether it's a poor urban neighborhood or it's a rural neighborhood that is maybe poor, but also maybe just not wired well, this has emerged as a major disparity in access, one that we need probably to think about correcting, not as something that we see as a privilege that everyone buys into, but as something that we see as kind of just general infrastructure in order to make sure that everyone has access to this good care. And then there's this third piece, and something that I know we talked about when preparing for this presentation, which is this concept of diminished intimacy. So, and we'll talk about this a little bit more, but something in psychiatry that is really huge is that connection to patients. But let's be very clear, that's a big deal no matter what type of care you're getting. We have lots of data to show that that connection we have with patients is really core and key to actually improving their sense of whether or not we're doing good work, and is actually related to better outcomes. If you feel more connected with the people that are providing care, you're more likely to adhere, and you're more likely to adhere well to what we're asking you to do, meaning you're more likely to get it right, your efforts better. In a virtual world, the concern is that this is going to create problems. Problems really with empathy, right? Problems with feeling like I'm connected to the person that I'm working with. The good news, and we've had a lot of research going back actually about a decade on this mental health side, is that outcomes, it turns out, look to be about the same with virtual mental health interventions as they do for physical health, in-person mental health interventions. And actually, when virtual is mixed with live, it doesn't appear to cause a lot of trouble. But when I'm meeting someone and developing a relationship entirely virtual, that creates a new need to connect with people in different ways. I'll reflect just rhetorically a little bit with you guys to think about all the things you've done in the work you're doing over the last 6 months to readjust how you make connections with people virtually. I've had to get much, much better at using things like breakout rooms, but I've also had to get much better at using verbal cues to do things that normally would have happened more effectively or efficiently by eye contact. And with regard to patients, it's incumbent upon providers to leverage and develop this slightly different skill set to make the virtual environment actually feel intimate. And that's a big deal. When it comes to providers, there's a lot of the same pluses and minuses. So providers, this is great. We also love this. This is convenient for me. I can just sign right on and get someone in right away. Someone can call me and I can say, I have an opening in 5 minutes, and I can just get them in right away. It also means that I can be, wherever I am in the world, I can get on and see someone. So if I've got a mix of, for instance, administrative and clinical duties, my ability to kind of shift and get on a video screen is far more convenient than having to run back to whatever office I normally see people at. That's a big deal. It's flexible. It allows me to really be flexible with how I approach my day. It means that I can have some of my time at home and also some of my time at work. This, this work-life balance, this concept of maybe I don't have to commute today, buys me extra time. It allows me to stay at home and kind of share some of the duties of caregiving if I'm a parent, in a 2-parent household. It allows me to be more present at home if I've got things that need to happen around the house while I'm also doing work. Big deal for provider quality of life, right? It does, in fact, seem to have bumped our show rates by about 50% from where they were. So we had pretty good show rates, around 88% in the Department of Psychiatry. Those are now regularly hanging out 93, 94%. So that means that I'm more likely to see people. They're more likely to engage in care. They're more likely to get better outcomes. And I'm wasting less of the resource of me and my time, right? Those are all good things. And then finally, reduce cost. That's, if I can have a lot of my workforce virtual, then I can have less space, and that's a good thing too. Challenges though, and this is really, really important. I'm going to come back to diminished intimacy, but we'll start with technology learning curve. So we all had to do that too. We all had to figure this out. Some people had an easier time with others, but we had the extra burden of both having to do virtual video visits, but also then figure out how to leverage and do our note writing at the same time while looking at a record, while figuring out how to be in touch with you. That was several steps harder. We had to figure out how to manage our schedule. We had to figure out how to invite people to Zoom, all that stuff. We had new workflows. So there's the technology piece, which is using more technology and dealing with more of this input. There's also the new workflows, which is, well, we no longer are checking people in office. Now we're checking people in at home. We're no longer using paper scripts. We're now everything's e-scribing, and we have to do that in a very specific way. We had to figure out when do we, if we have to gather information, how do we gather that information now in a way that makes sense? And that leads to this technology overload, which we're hearing a lot. If there's one thing that I'm hearing from providers, and again, this is true almost everywhere, it's that this feeling of not only looking at one screen all day, but having to toggle back and forth is overwhelming for a lot of providers. It's not what we signed up for, and it can be a lot. It's weighed against, boy, the flexibility and convenience is awesome, but maybe I'm a little fatigued by it. And then we get to this concept of diminished intimacy. So on the provider side, in particular on psychiatry, we're acutely aware that having to connect with patients is key to getting the results that we want to get. And so that's a challenge we have to do, and we have to take it upon ourselves to be able to make sure that we are connecting with people. And that's stuff we're not used to doing in those ways. We were used to using our body language. That's kind of gone. We're used to using things like, small sounds, a breath, eye contact in the right way, squaring, all these things, they're just gone. And so how do we make sure people feel heard when it's really easy to just glaze over? And frankly, right now I can be doing email while I'm talking with you, which a lot of you have done. So you got that piece, right? And then there's a question about the capacity of what we can do, right? I can't do all the same things on video that I didn't do in person. I'll use child psychiatry as an example. It's really hard in a video to understand, engage when I'm interviewing a child, how they're interacting with their parent and what that looks like. So if I want to get a sense of the relationship between a parent and a child to better understand a child's mental health issues, that ability to kind of understand and assess that over video is diminished, and it's not as good. And so we have to figure out and we have to learn what is as good, which we don't quite know yet, and what isn't as good. And we've got a sense, but no real great data on that. That's going to take some time. So there's, to take a step back from the provider patient side, the last piece of this is the insurance companies. So let's be very clear. Insurers were very skeptical, payers, Medicare included. This is not a knock on that industry. It's just they were very skeptical that there was going to be a lot of value to this. And so there was a lot of dragging the feet, a lot of wanting to go through a lot of processes, a lot of wanting to kind of cost adjust in very specific ways. And it was slowing down what I think was a really important innovation that needed to be accelerated. And let's be very clear, for the most part, they've taken some time to adjust, but payers have really come this direction, and they really have seen the light. I think there's a lot of agreement that virtual is here to stay, at nearly the level we have it, which is to say, paying pretty close to parity for virtual visits when we clinically think it's appropriate. That isn't to say that there aren't going to be some extra restrictions that are on there right now. A really big piece of what we're doing virtually right now is telephone. There's a lot of debate as to what's fair for people who don't have access to video, and how we get paid and how they get access to care. There's some debate there, and I think that's a good thing. I think it's good for us to be debating the gray areas. And I'm thrilled that, again, 6 months ago, I struggled to get a half day of a clinic. And now the question isn't what can I do? It's what shouldn't I do? And that's a great place to be having. And it's been actually pretty collaborative with the insurers. We have a lot of relationships with payers. It's been pretty collaborative in terms of what we've been doing and how we've been doing it. And there'll be some really, over the next 6 to 12 months, and really over the next 5 years, you're going to see some, what I think are really important discussions about what the boundaries of this should be and how it should be compensated and what we should be compensated for. But that's a good thing. And again, same thing. So, couple of quick insurance coverage considerations that are interesting for us to kind of think about is parity. So this concept of parity is, am I getting paid the same amount for a face-to-face versus a virtual visit? And so the longstanding healthcare industry standard has been that the facilities are worked into our cost of care. Well, if I got everybody working from home, then the facility cost shouldn't be an issue. And so I shouldn't have to pay as much for the service. And so that's something that we're going to be spending some time over the next few years figuring out, is how much cheaper is it? If I still have to have an office some of the time, does that allow us to actually shave any costs? We still have to have the same manpower? At the same time, depending on the type of service you're doing, some of that manpower is less or more. In psychiatry, we're pretty close to the same manpower because we still have to have people scheduling. I still have to have the clinician doing the work. In primary care, I might not need to see an RN and an MA. I might not need to go through everybody. And so there might truly be some efficiencies there. And we're going to have to figure that out. Talked about telephone treatment. An area that I think is really interesting, and I'm happy to talk more about, is this concept of what we refer to in the industry as asynchronous treatment, which what I'd say colloquially is email treatment, right? It's, the ability, what can I accomplish effectively with a back and forth communication that does not require us to be talking at the same time to each other. And in some senses, this is silly. Of course, for instance, psychotherapy isn't going to be quite as good if you're doing it where I type an email and 3 hours later you type me an email back. However, there is an awful lot that we probably can do through a little bit of communication back and forth. And there's a real question right now, because this is happening a lot more. What ought we be covering? And is this something we ought to work in there? This, for the most part, was considered a cost of business for the pro fee you generated for in-office. So I see someone in office, and then if I got to answer emails and communicate and answer phone calls back, that was just part of that you just had to work that into your day and make it work. But let's be clear, if you're not incentivized to do something, then this becomes a burden that you minimize as much as possible. What if, from a patient-centered service design capacity, we maximize this and figured out everything we could do that created the most value and the most benefit? That would be something. And we're actually having these conversations now. They're not front and center, these are. But the concept of what we can do asynchronously and how we ought to be compensated for that and the value it provides the patient is a real thing that we ought to be thinking. And it really ought to be through the lens of what provides value to patients. What does the future hold? So within this, what you're going to see is a lot more innovation around home technology. I had a conversation our meeting with a tech company a few weeks ago related to MD Anderson, which is, as you guys may know, a big cancer hospital that's got a national presence. And they've actually built machines that you can put in one space that will actually collect blood samples for you, and you can stick them in there. And then a while away, can actually use that to diagnose you and get care. There's machines that'll actually do EKGs for you. There's machines that will do a whole lot of things. And what we're going to innovate there is really quite fascinating. The Cleveland Clinic right now is actually in partnership with Case Western. They are using a technology, the HoloLens is I think what it's called, which is allowing them to do surgeries virtually with machines. You're not going to see in-home surgeries, I don't think, but you are going to start to see increasing amounts of what can we shift to the home that would actually enhance value, and that's always about value. A quick warning, of course, is that anytime you open up a space, you open up for innovation. Not all innovation is good. Not all innovation produces more value, even if it gets compensated. And this has been a central challenge for healthcare overall, one that's come into sharp relief over the last year, is that we have done a lot of innovation around quality that has created a lot of new stuff. Not all the new stuff that we've created is good or provides great value. But we haven't done a good job of culling that out and actually really honing in on the things that provide the best outcomes and getting rid of the rest of it, because there's so much that's invested. There's a lot of people who are invested in not changing the status quo. That's going to be a big issue in this space. I think it is undeniable, as I've mentioned before, we're going to have national conversations and state level conversations around internet infrastructure, and you're starting to see those happen. The degree to which we talk about a national infrastructure plan, how much that includes the ability for people to get connected, is probably going to be a real big thing. Some of this is about socioeconomic status. Some of this is just about, for whatever reason in our country, rural areas, it's just not something we tried as hard to do. And that almost certainly had to do with the fact that there are less paying customers per square mile. So no one was economically invested in that. So that brings us back to this question of what's the role for us as a country to come together and say, we think of this like we think of roads, and we need to have them available to everybody. Major issues around this, as I've also alluded to before, is and I'll actually start with intrastate telehealth competition. So is the Cleveland Clinic and UH going to now compete, University Hospital is going to compete with Nationwide in Columbus, which is a major hospital system down there. Is this a thing that's now going to happen where our competition is no longer the person next door? It's now hospitals around the country. And let's be very clear, we have national brands, and there are people who actually want to come get care from us. The place where this is going to create a lot of friction is in local community hospitals. And there are two ways this is going to happen. One is a hospital that's not part of, for instance, University Hospital. So if we create a lot more virtual care, and I can centralize that virtual care to a main campus or get you access to that, then I'm competing with a rural hospital maybe, and their reputation as for expertise. This is also going to happen, though, within our system. So University Hospitals, for instance, has 18 hospitals, and we have primary care offices everywhere. If we find that there's an efficiency in having a lot of those services consolidated to our central campus, that means that those jobs are also coming to our central campus. And that creates an interesting conundrum around the benefit that patients get versus the major economic engine that drives a lot of rural economies. And if people are not aware of this, the rural economies in our country are the number one employer in rural economies right now is actually healthcare. So that's not a small thing, right? That's going to be an issue. If we do consolidate, that's potentially a great efficiency, but that may cause a lot of problems with different sectors of the economy in different regions. The same thing could happen with, say, let's say population centers like Cleveland versus population centers like New York City. To what degree does Cleveland Clinic outcompete for New York City's business and vice versa? That gets into this interstate telehealth competition. And what are we going to see here? I will tell you that absolutely every healthcare system right now is having conversations about, oh, well, now that these rules are different and we have this infrastructure and we have patients, for instance, in Ohio that vacation in winter down in Florida, what if we just get a whole bunch of our providers credentialed and licensed in Florida and then have them do virtual care? Wouldn't that be great? What that means for the hospitals in Florida, though, is a really interesting thing. And that's something we're going to be grappling with. And then there are other pieces around how we deliver care. If I can now do everything virtually, it takes me mere seconds for me, the psychiatrist, to jump in on a primary care meeting and to at the same time have a cardiologist jump in on the primary care meeting. So now we start to think about doing workflows entirely differently, and that question of value created becomes really central. And then I don't have to, the other thing that we might start leaping toward, and just kind of really in the future, I've already seen technology and I've played with technology where I put a headset on and I'm talking to someone as if they're in the room with me virtually. It actually makes them look like a 3D image. It's not awesome. It doesn't look this good, but it's there. And so there's this thing, right, where we're going to start to see really the world of the future. What will it look like? What if we get really, really good at doing these kind of 3D images? What will our own work lives look like? But in healthcare, this could be a pretty big deal. And what you've seen here is a setup. This is what therapy might look like in the future, right? This is what psychotherapy might start looking like. I don't know. Issues of empathy become a big deal. But in this case, you'll see we've solved the problem of body language, right? If we get good at that. So I use this picture very intentionally. This concept of being in person and being in present with someone is not small. And the idea, human touch matters. We actually do have studies that show that putting a hand on a shoulder, holding someone's hand when you're giving them bad news, or just talking with them about a difficult thing matters. Being in the same room, sitting and seeing someone see you at level. There's actually studies that show if I deliver news to someone in an office while I'm standing versus while I'm sitting, gets received very differently. All of these things go away, which are the things that allow us to feel good about getting interactions. And ultimately, they're what help patients get better care. So those are things we're going to have to solve for. And I don't think we have great answers for those yet. Wouldn't be surprised to start seeing technology that actually tries to get at this domain, but we're probably still pretty far away from that. So that's most of what I had to say. I think I actually hit my target time pretty well. So I'll stop there. I hope that was thought-provoking. I hope it was interesting. And I'm around for the next half hour to answer any questions people might have.
So if everyone could place their questions in the chat, Dr. Runnels, we're going to start off with two that we have. The first being, and you did speak a little bit to this in terms of mentioning the Cleveland Clinic, but just kind of a sense of how quickly did various healthcare institutions, insurance companies, et cetera, in Cleveland come together to determine solutions in providing patient care during that, as you said, almost 3-day, like you had in one day things changed in the midst of the pandemic. And was there a collaboration and sharing of these best practices that you shared that were university hospitals, but across the different healthcare systems and providers?
So to add a little more detail, when the crisis hit, and this was a healthcare system crisis, right? We had to very quickly figure out how to do a lot of things very differently. Most major hospital systems instituted something kind of like what we call a HIC structure, which is a crisis administrative structure that's a little bit more hierarchical and top down, but is separate from our normal administrative structure. So we created an entire infrastructure whose entire job was to retrofit our system to be good at managing all things related to COVID. We had to do that because there were things like, how do you manage, and you may have had another talk about this, but how do you manage ICU beds? What are precautions you're taking? How do you get, all that kind of stuff, right? In Cleveland, the structures that got instituted at our major institutions all immediately also created cross connections. There was actually a group of people that were the leader for these structures that then were talking on a daily basis. And they were saying things like, here's what we're doing, here's the procedures we used, what are you guys doing, here's how we're dealing with this. It just happened very organically. It turns out the leadership of our major health systems in Cleveland actually have a pretty good relationship, and we're already communicating and collaborating. And that's not to say there's not healthy competition, but the reality is we had already really built these bridges, and that really suited us very well because we shared information back and forth like that, and that really did help us all understand better what we were doing and get things better quicker.
Wonderful, thank you. We have a question from Jenny Flynn. She sees how telemed works well with existing patients, but wants to understand what your experience was like onboarding new patients virtually, especially just given the rise in anxiety and depression that came with the COVID pandemic.
So there's a couple of questions in there. I'm going to take them each separately. So the first thing is just the experience of that people had. We had a couple of interesting things happen. The first was everyone was thankful that there was a way to get in despite the risk, right? So the initial reaction was, thank God I can still get care. The second reaction was, after a while, and this started to become normal, there were a set of patients who really wanted to get in and see people. And so we created a structure that, so that people could come in and have a live in-person visit if it was deemed okay. And what happened was the patients had a demand for this, they'd schedule it, and then the day before they'd cancel and say, I'd rather do virtual. They got cold feet, which is to say, and this is a really important lesson for the COVID economy in general, people liked the idea of seeing people in person and started down that road and then got cold feet because they were scared about getting sick. And so even though we had a mechanism for doing a pretty safe visit, and even though clearly there were people that were longing for that connection, when it came down to it, their fear of getting sick was trumping that, which is just to say the demand has not materialized like we thought it might. That said, that's still something we're grappling with. There are clearly patients and providers who miss and understand that in-person visits, particularly for new patients, would be good. At the same time, I will say it hasn't been a major complaint. We expected more complaints. Most people have acclimated, and actually most of the new onboarded patients are feeling good and giving us good feedback that they feel connected, and providers have acclimated. Their initial fear was that connection can't happen. That's gone away too. People are doing okay with this. And I think a lot of those skills I talked about having developed, it turns out we all develop them naturally when we have to. And I think we're going to see that over time, not just in healthcare. The last part of that question is, there has clearly been a rise in anxiety and depression. There's been a rise in suicide rates. There's been a rise in chemical overdoses, and particularly chemical overdose deaths. And we thought that would mean we were going to have a massive spike, and we actually prepared. I won't get into the details, but we actually prepared and restructured everything with the idea we were going to get walloped about 2 months after COVID with a spike in mental health stuff. We've had a bit of an increase. It has not been anywhere near what we thought. We thought our ERs would get creamed with people who were panicking and traumatized and all this. Little spike here and there, nothing like what we expected, particularly given, as you point out, that we know that people are, like, there was a survey out there that said people under 40, to the tune of something like 60% of people under 40 who lost their jobs have contemplated seriously suicide. Surely those people would have come in and gotten care, and we're not seeing it yet. This is a patient-centered question, right? We've designed our services to not be something that people access, and we need to solve that because that's absolutely a problem. The way we are presenting our services and the way people access those services hasn't captured the need that we know is out there, and that is going to lead to bad outcomes down the road, by way, most concretely, obviously, of people dying by suicide, but obviously other types of things too. And that's not just, again, psychiatry. This is lots of stuff. This is all types of healthcare.
Thank you. Another question from Steve Smith. Are there other ways professional healthcare and medical associations could better support members like you going forward? In particular, what are you and others looking for mid-pandemic or post-pandemic that's different from what you were seeking at the start of COVID? And that's from Steve Smith of AMC.
The themes I've seen emerge at the national advocacy level and kind of the support organizations, the themes are broadly in a number of areas. The first is dealing and coping with the burnout that comes from this, from all the learning, right? So there's a burnout piece, and how do I, and this is true in a lot of work. I don't think this is just healthcare, but how do I, as a professional, ensure that I'm not getting consumed at home by this job now that those lines are blurred and I can see anybody anytime? How do I ensure that my work doesn't kind of eat my sanity, if you will? And that's particularly acute for healthcare providers who are very mission oriented and will do anything to help anybody most of the time, and it's really easy for them to get caught up and actually just see their days go away. Second thing I'm seeing, maybe a little related to that, is how do we ensure that patients, how do we ensure patients have access? So whether it's advocacy for national policy or making sure that patients are educated about this, there's this real need to help people feel okay about the technology and then make sure they have access when they can. It's not equitable right now. Just very clearly that one of the big conversations that came out of all this was the inequity in our system. That is probably the biggest single theme I'm seeing, is inequity as a driver of outcomes. People who have internet are privileged, and that's just the way it is. And, that's, not an indictment of anybody. It's a recognition that we have a system that is inequitably distributed. And that is maybe the most passionate thing I've seen people talk about. There's certainly right now active and ongoing, very emotionally charged discussions about what long-term coverage looks like. There was a period about 2 months ago where payers we're like, all right, COVID's kind of under control. And so we're going to start rolling back some of our extra protections or extra coverage options. And with the recent surge, that talk has gone away. But there will be a point at which providers are clearly seeing massive benefit from telephone, from virtual care that otherwise might be kind of at risk of getting canceled out. So there's that advocacy piece too. And then the last one is, and this is big, how do you connect with your colleagues? So I'm used to going to an office and having this connection. So how do I stay connected? And we've done a lot with how to create community when the community's been dispersed. There's a lot of innovation that needs to happen around that area.
So that brings us actually to a great wrap-up question, and also is a nice promotion for a future presentation we have on healthcare as a social determinant, essentially. But my question was going to be, you mentioned this briefly, but what role do you see healthcare providing in that advocacy component? You mentioned one of the huge hurdles is the access to care virtually, based on rural, low income, things of that nature. What do you foresee your role being in advocacy for that equitable infrastructure, or that infrastructure being developed? And then a second part of that question as it relates to advocacy, and then we'll wrap up after that and Gordon will take over. Were there any permissions granted? You mentioned the state kind of, wiped out some HIPAA stuff that were temporary, that, there needs to be advocacy for maintaining so that the future of this virtual healthcare can continue.
So thank you for reminding me of that. So I hadn't thought about that because it has caused no hiccups as of yet. I'll use an example. So when I provide a controlled prescription for a medication called Suboxone, which is a treatment that saves lives for people who are opioid addicts, it saves lives by they take that, and then if I wanted to use heroin or a painkiller in a negative way, it would stop that from having an impact on me. So it actually is a really, really life-saving medications. There are a lot of rules in place by what I need to do to prescribe that, related to where I see the patient, how I see the patient, what technology I use when I'm seeing the patient, that are all currently suspended but haven't been formally rewritten. It's a good example, and there are lots of examples across different pieces where that has saved lives, and that level of access to that medication is really big. There are a lot of restrictive laws out there that probably were unnecessarily restrictive. That's one of them. And so there are definitely areas of advocacy around those kinds of policies and procedures that we need to be clear about. Different professional organizations should take stock. What are the things that change, that have revolutionized or done things better? And where do we need to kind of partner with other organizations of other professional groups that are the same? When you get multiple organizations together, as many of you know, the messaging can be very potent and powerful. And so that's, you should be gathering that data from your membership to figure out what their individual areas of discovery are. And then to end on social determinants. So one of my roles in my system, I actually am the system lead for our response, our overall development of social, both evaluating and managing social determinants. And there is two pieces of that question. You'll hear a lot more about it, I think, in the next presentation. The first is, here's the deal. Social determinants are not direct healthcare, and yet they are massively tied to healthcare, and you cannot separate them, which is to say, healthcare systems are, whether they like it or not, in the business of dealing with the pieces of social determinants. Value-based alternative payment models, value-based care payment models like accountable care organizations, if they make us responsible for outcomes, and if I know that outcomes are heavily impacted by social determinants, then I have a massive economic interest in dealing with that. And that's just the reality. In that regard, we as systems are absolutely, and I'm telling you, most of the major systems in the country are having these discussions. We're going to have to get in the business of either ensuring that these services are there or building them on our own. Mayo Clinic in Minnesota is actually building housing for people who are housing unstable and have major health conditions. They are building housing. Is that what every system needs to do? I don't think every system will get into the housing game, but you're going to see it happen. In that regard, we're going to get into spaces that seem not directly related to healthcare, because that's what needs to happen, because that's where it's tied, right? The other piece of this is, what's our role in advocating to the government? And the reality is we haven't invested in this either, because we weren't in control of outcomes. And if we're in control of outcomes and we're responsible for that, and we have to deal with that, you're going to start to see healthcare systems, particularly those in the value game, that are starting to advocate that local and state and national governments, federal governments, are taking this seriously and considering some of these things like infrastructure. And I will tell you the two major areas are going to be connectedness to the internet and transportation. But childcare is in there, and the food insecurity is one that'll probably be more local, but childcare is in there as well. Are we going to have a national childcare policy, all that kind of stuff? These things are going to be things that healthcare systems are now kind of interested in. They have an economic incentive to do. And I would add, most of us have wanted to deal with this. And now that it's there and it's visible and we can see the impact and we know what it means, we're going to start chirping up anyway, because it's the right thing to do.
Thank you so much. If I don't see any other questions, so with that, we'll turn it over to Gordon Taylor, our Vice President of Convention Sales and Services.
Thanks, Anne-Marie, and thank you, Dr. Runnels. That was incredibly informative and engaging. And I feel really lucky to actually be able to spend time with you today to hear about this. Kind of like an insider's point of view on everything you went through. I think it's interesting how much of it can parallel to what we're doing in meetings and conventions as well. Yeah. It's just like in everything you're saying about like what it's like to go to work every day and look at a screen for this long. But the information was fantastic, and I really appreciate it. In closing, just for everybody on here, I'd like to thank you for joining us today with Destination Cleveland, and also want to thank the Association Forum for the opportunity to have this webinar. And speaking of webinars, I want to remind everybody we have two more upcoming sessions. One of them is coming this Tuesday. So it's Tuesday, October 27th. It's 10 a.m. to 11:30 Central and 11 a.m. to 12:30 Eastern. It's what Dr. Runnels was just talking about. It's the topic is social determinants of health. It's with Dr. Nabil Shahade. He is with Metro Systems. He's an executive vice president there. And then also on Friday, November 6th, we have Dr. Nazar Zine, who is with the Cleveland Clinic, and will be speaking on the future of medical tourism as an export industry in the post-COVID era. So that's what we have for you today. We thank you again for joining us. Dr. Runnels, thanks again for your time, and we look forward to seeing you hopefully on a future webinar that we have coming up. Thank you.
Thanks, everybody. Really appreciate it.